All right, let's dive right in. We're going to be tackling a topic that, if you're a pathology trainee, is absolutely essential: the CAP protocol for Ewing sarcoma biopsies. And let's be real, getting this right isn't just about ticking a box on an exam. It's about making sure you're providing the absolute best information for your pediatric patients.
So picture it. The biopsy arrives. It's a classic small blue round cell tumor. The clinician is thinking, Ewing sarcoma. Are you ready? Do you know exactly what to do to create a report that is accurate, compliant, and actually useful? Well, that's what we're here to do. Make sure the answer to that question is a confident yes.
We're going to follow what I like to call the specimen's journey. First, we'll figure out the scope. When do you even use this thing? Then we'll talk about how to handle the specimen when it hits your bench. After that, we'll cover the key data points you have to report, decode the ancillary studies, and finally, pull it all together in a perfect synoptic report. Let's get to it. Okay, first things first, scope and purpose. This might seem basic, but if you don't know exactly when to apply this protocol, you're starting off on the wrong foot. Getting this right is totally non-negotiable for your lab's accreditation, and even more importantly, for making sure the patient gets the right treatment from day one.
So let's get specific. Look here. The protocol is very clear. You use this for biopsy specimens, not big resections. Those have their own protocol. It's for pediatric patients. Why? Because adult Ewing sarcoma can be a different beast. And, super important, you do not use this for other round cell sarcomas that look alike but have different genetics, like the ones with CIC or B-core fusions. Knowing these boundaries is your first and maybe most important job.
All right, now that we know when to use the protocol, let's talk about what to do when that fresh biopsy actually arrives. I'm not kidding, the decisions you make in the first few minutes can make or break the entire case. The first steps are absolutely critical. With a tiny biopsy, you have to triage. Think of it like this. Step 1. You feed the eyes. You have to get tissue into formalin for your slides. That's your foundation. Step 2. You feed the genes. You need tissue for molecular testing, and how you prep it is huge. And step 3. You bank for the future. Snap freezing a little bit of tumor could be critical for future research or clinical trials. And this right here, this is the why behind that second step. This quote is a massive warning sign. If you get a bone biopsy and throw it into a harsh acid to decalcify it, you will shred the DNA and RNA. You could literally make it impossible to do the molecular tests that confirm the diagnosis. Choosing an EDTA-based solution, it's a small choice with enormous consequences. So the specimen is handled, you've looked at the slides, now it's time to write the report. Let's walk through the absolute must-have data points that CAP requires you to document. These are the essentials. Here they are, the basics: procedure type, where the tumor is, and if you see any vascular invasion. But you see those little asterisks next to tumor size and margin status? That's key. You only report those for an excisional biopsy, where the whole thing was taken out. It just makes sense, right? You can't really comment on the total size or the margins from just a tiny core biopsy. Now we get to my favorite part, the detective work. Your morphology gets you into the right ballpark of a small blue round cell tumor, but it's the ancillary studies, the IHC and the molecular, that let you definitively say, yes, this is Ewing sarcoma. This is where you uncover the truth. When you hear Ewing sarcoma, your brain should immediately think CD99. It's the classic stain. And you're looking for this beautiful, strong, diffuse staining that just lights up the cell membrane. When you see that pattern, it's a major clue. But, and this is a really big but, CD99 is not specific at all. Just look at this list. A whole bunch of other tumors can be CD99 positive too. This is exactly why you can never ever make the diagnosis on CD99 alone. You have to use a smart panel of stains to rule out all these mimics. And that brings us to the modern definition of Ewing sarcoma, straight from the World Health Organization. See, it's not just about how it looks anymore. It is defined by its genetics. Ewing sarcoma is a tumor that has a specific gene fusion, usually involving the EWSR1 gene. That is the molecular truth we're after. This chart breaks it down perfectly. The vast majority of cases, we're talking 90 to 95%, are driven by that EWSR1 Fly1 fusion. The next one up is EWSR1 ERG, but don't ignore that little slice at the bottom. A small number of cases have other, rarer fusions, and you need to know that they exist. Which leads us to this incredibly important point. If your lab runs a specific test that only looks for that one common fusion, EWSR1, Fly1, and it comes back negative, you are not done. You have not ruled out Ewing sarcoma. You could easily be looking at a case with that ERG fusion or one of the other rare ones. That's why sometimes you need broader tests, like FISH if the first one is negative, but you're still suspicious. Okay, we've done the workup, we have our diagnosis, time for the final act, putting everything together in the synoptic report. And this is not just paperwork, folks. This is about communicating your findings in a clear, standardized way so that everyone on the patient's team can understand and use the information. CAP is very, very specific about the format. It has to be this data element response structure. So it's tumor site, osseous, on its own line. It's not a sentence buried in a paragraph that says, the tumor is osseous. This strict format means no one ever has to go hunting for the critical data. It's clean, it's clear, and it is required. And here is the other golden rule of synoptic reporting. You have to put all of these required elements together in one spot. You can't have some in the diagnosis line and a few more down in the comments section. They all have to be grouped together in a single block. This makes it incredibly easy for the clinical team to find what they need in a flash. So there you have it. We followed the specimen from the moment it arrived all the way to the final report. This protocol, it's the framework, it's the guardrails that keep everything consistent and complete. But it's your expertise, your eye, your judgment, your understanding of the molecular details that really brings that framework to life. So the real question is, how are you going to use this structure to tell the complete story of your next patient's case?